Hi, everyone. Thanks for joining us today. I'm Noah Gibson, a fourth-year PhD student in sociology and public policy at Duke, and I will be the moderator of today's talk. The name of our panel is Thinking Locally About Food Insecurity, Community-Level Research on Food and Nutrition Access. And today's session will be recorded and posted publicly. Following the panelists' presentations, we will have a Q&A. Online participants can put questions into the Q&A tab at any time, and people in the room can raise their hands during the Q&A period. So I'm very excited to talk about food and nutrition access. Food insecurity is one of the most important global health issues facing us today. And it's a topic that touches on a wide array of issues, such as climate change, food systems and production, poverty, and importantly, health equity. The talk today will focus on food and nutrition access in the US and community level programs in Durham. I know this is an issue that really spans everywhere across the globe, but today we are focusing on the US context and more local level initiatives that are happening in Durham, North Carolina. And focusing on community level research is important because it helps shed light on gaps with federal food assistance policies and how interventions can impact individuals. So I think everyone could have noticed during the COVID-19 pandemic that there were huge lines outside of food pantries. There was ridiculous long lines of cars waiting on highways to get food. So I think it really raised awareness and brought attention to this issue and the role that food pantries and the local policy and initiatives play in addressing food insecurity. And so I'm excited to introduce our panelists for today's talk, who are all involved in community grounded research and are working closely with local partners to address food and nutrition access in Durham. Their full bios are available on the end. So first on the end is Steph Bryant. She's a clinical research coordinator for the Duke Center for Childhood Obesity Research and serves as a primary research coordinator on the Nourish study. Scott Brummel is the assistant director of food nutrition security for Duke Health. It's the inaugural position, just started out this year, right? And Scott also serves as a program manager for the Fresh Produce program, which is part of the Duke Next Student Organization Root Causes. And then Elijah LePay is a senior at Duke University pursuing a degree in migrant health and healthcare. Elijah helps facilitate the operations and research initiatives of Root Causes Fresh Produce program and is a community resource navigator at Lincoln Community Health Center. And so first, I'll briefly go through slides to provide some context on food insecurity in the US, and then we'll hear from our panelists. So first, what is food insecurity? Food insecurity is defined as a lack of consistent access to enough food for every person in the household to live an active and healthy life. And this photo is actually from Dallas, Texas during COVID. And there are many photos like this across many different cities in the US, but kind of highlights the holes that we have in federal level policies and the real need for local programs and food pantries to address food insecurity. Those are food lines. Yeah, those cars are lined up on the highway, and people are going around providing food to those cars. And so I think it's kind of helpful to think about how food insecurity is measured or defined, because it is a topic you hear about a lot, but maybe you don't know exactly what it refers to. And so I have a few questions just so you need a feel for how it's measured, but typically households are asked 10 questions related to food and food access, and it's 18 questions if the household has children. And so they read statements like, the food that we bought just didn't last and we didn't have money to get more. and Nick respond was that often, sometimes, or never true. There's another one says we couldn't afford to eat balanced meals, or that often, sometimes, but never true. Another example, in the last 12 months, were you ever hungry but didn't eat because there wasn't enough food? You can kind of see a common theme across these questions. It's not just about accessing food, but it's also about the worry and stress related to this financial strain. So here's kind of a graph that shows the food insecurity rate from 2001 to 2022. As you can see, if it's consistent with economic trends in the US, there's a huge spike during 2008. And somewhat surprisingly, the food insecurity rate remained around the same rate at the beginning of COVID-19 pandemic. And this was in large part due to huge increases in federal level policies and money that people were receiving. But the most recent data is going to come out in 2022, 3 and 4, find that there is a huge spike in food insecurity as those policies have been pulled back. And I think it's also important to note that households experience food insecurity for different durations at different levels of severity. And so this is a table from a paper I'm working on currently. It shows the prevalence of chronic food insecurity in the US. And so if you look across 3 waves, in this data set, it's 2015, 2017, and 2019, you can see that around 20% of households experienced food insecurity for at least 1 year, and 5.5% experienced chronic or persistent food insecurity. So they were food insecure across all 3 waves. And so I think it's important to kind of highlight this because the types of policies and initiatives that households that experience chronic insecurity need are very different than those that may be kind of transitioning in and out of food insecurity. And I'd also like to highlight that there are large disparities in food insecurity rates. So this is kind of the same graph, but split by race and ethnic groups. You can see that for Black and Hispanic households, the food insecurity rate is around double, sometimes even more than that of white non-Hispanic households. And if you look more specifically at 2019, the food insecurity rate actually spiked for Black and Hispanic households while it decreased for white households. So there's a lot more papers coming out about this now, but it really highlights that there are differences in access to resources too. So it is really shocking that it would spike for certain groups while decline for others at such a time like COVID-19 pandemic. And I know I'm throwing a lot of graphs at you, but I think this is the last one. It also highlights that there are disparities across geographic areas. And so looking at North Carolina counties in particular, the food insecurity rate in Union County was 8.5% in 2020, which was the lowest of any county in North Carolina. And just a few counties over in Scotland County, the food insecurity rate was 20.4%, which was the highest of any county. So I think it highlights it's really important to consider local context when examining something like food insecurity. Just to briefly touch on this, food insecurity is associated with many negative health outcomes such as diabetes and hypertension. And the relationship between food insecurity and health is bidirectional, really difficult to kind of disentangle. So there's been a lot of good research recently thinking about food as medicine as a way to address health inequities. And we'll kind of get into that more in our talk today. But thinking of food and nutrition access as a key driver of health and health equity. And there are a few really big programs, federal food assistance programs that are made to address food insecurity in the US. The main one is SNAP, which serves around 41 million people per month, which is about 12.5% of the US population. Also the National School Lunch Program, which serves free and reduced price meals to around 30 million students each year. and WIC, which is targeted to women and infants and young children, serves around 6.3 million participants per month, which is an estimated 39% of all infants. I didn't know that until today, so that seems like a very shocking statistic. And so it's clear that taken together, the food assistance programs make up a huge bulk that are a crucial part of the U.S. that that. So lastly, I'd like to quickly introduce root causes, which Elijah and Scott will talk more about. But we're doing a Bath Connections project where we're interviewing and surveying root causes participants. And what root causes does is it delivers fresh produce to around 350, I guess it's more, to 400 Durham households, and there's also a walkout table at the facility for people to walk out. So now I'll pass it to Steph, and she's going to talk about her work on the Nourish study.
Hey everyone, I'm Steph. Hi to everyone who's in the room, everyone who's online. So I'm Steph. I am coming at this, so I'm a research coordinator right now, and I'm working on starting up the Nourish study with Dr. Sarah Armstrong. But to give you guys some context of where I'm coming from, I thought it'd be really important to give a little bit of my background. So before being a research coordinator, I am a registered dietitian, but I was practicing at Do Healthy Lifestyles. It's housed within a pediatric clinic within Durham. So you'll see up top is the clinic that I worked at for almost 5 years on a multidisciplinary team, and it was pretty amazing to do that work. And then below you'll see a picture of some of our kids. Our program has we have a clinical component, and then we have a fitness activity component that kids can participate in after school. So I just wanted to show both sides of that. As a dietitian on this team, I worked with doctors, I worked with mental health professionals, other dietitians, physical therapists. We are a very progressive clinic that treats childhood obesity from a very non-weight focused point of view. So once kids come to see us, we really are more of a wellness clinic, which is important. So we're also a trauma-informed clinic, and so we take into account social determinants of health. We don't just say, hey, eat more, eat better, move more, and then see you later. We really try to wrap our arms around families and really take care of them and do the best for them. What comes along with that, though, is that you first want to do no harm, and you want to make sure that anything that you're asking about, you have a resource to then address it. So I will say that for many years, we shied away from asking about food insecurity because we didn't have very many solid resources to address that food insecurity. It was scary to get the answer of yes, because it was like, well, what do I do now? So we would refer to food pantries around the county, but at the time, we're talking like 2016, 2017, 2018, the information that we had wasn't very solid. There were good food pantries around, but you never knew if the clinic staff spoke English and Spanish or another language and how welcoming it would be. And it could be stigmatizing to go to some of these places. And so that was just kind of a tougher component of the job. I will say that we did get connected with, there was a program through Reinvestment Partners that it was this really neat program called Bull City Bucks. And so we could refer patients and families to this program, and they could receive $40 to spend at Food Lion every month for a year on fresh, frozen, or canned fruits and vegetables, which was really neat. And that was a great resource to rely on, and it made it more comfortable to ask about food insecurity. In 2019, we did collaborate. We started a collaboration with the Food Bank of Central and South and Southern, Central and Eastern North Carolina. And they actually provided a grant to us to start a food pantry within our clinic. So we were able to start giving bags of food to participants that identified a need right there, which was really important. We started that program up in 2020. As you can imagine, that was very well timed. So summer of 2020, we were able to start giving food to participants. And I just want to say that another lifesaver during that program was the fresh produce program that Causes started up. So it was just another really great resource when families were struggling during the peak in the beginning of the pandemic to be able to provide them with guaranteed food at least every other week at the time, and it just felt much better to be able to do something about it. So with all that said, some more background about food insecurity that I know as a dietitian within the clinic, and I'm sure some of this isn't new to you, but 1 in 6 children in the United States right now live with food insecurity, but also 1 in 5 children have obesity. And so there's clearly a connection. The problem with this is that food insecurity experienced at a very young age is connected with also developing obesity that is experienced at age 3. It's very difficult to reverse. It's not to, I don't put that out there to be hopeless, but it just really signifies that interventions need to start really early on to avoid any down the road complications. There's a lot of mechanisms that hint towards the relationship between food insecurity and obesity, and I think we'll get to that a little bit later, but you have to take into account living with food insecurity. You probably are also experiencing poverty in other areas of your life. That also indicates that you're experiencing chronic stress, which, the stress of the parents is oftentimes unwittingly handed down to the children. And so this is something that experienced at a very young age, even subconsciously, can impact health down the road. Food insecurity is oftentimes treated with purchasing very accessible food, which happens to be not the healthiest. And the less healthy, cheaper, quicker to prepare food is also, unfortunately, what's sometimes provided by government assistance, like this, school breakfast program, great intention, lots of sugar. I won't go down that rabbit hole today. But so there's a lot of factors, and we can't just say, eat better, move more. It's not that simple. So knowing all that going into what I'm going to talk about. So Nourish Project, there's 2 pieces to this project. There's the clinical side, and that's the side that I'm working on. There is a basic science side that they're basically going to be mimicking food insecurity in rats and testing or checking on the outcomes from that. With the more clinical side, we're testing out 2 food insecurity interventions to see the impact that it has on babies' growth. So with our study design, we're going to hopefully, with the IRB now, we are hopefully going to enroll up to 228 participants into one of 2 arms. There will be a comparative group that will pull from the electronic health record. Just for equity's sake, we wanted to make sure that both of our intervention groups were receiving just that, the intervention, that we weren't going to enroll a group of people to then receive nothing. It just didn't feel very good. So we'll do a comparison with a cohort through the medical records. So basically we'll approach families when their kids are 9 to 12 months old that are on track to developing obesity. Our proxy for that, it's hard to pin down at that age, but we're going to say roughly greater than 20 pounds at 9 months. That is not a hard and fast rule, and we know it doesn't take a lot of other things into account. We'll be approaching families that receive Medicaid or are eligible for WIC. That's our proxy for possibly experiencing food insecurity. And from there, they'll get enrolled into one of 2 groups. Both groups will receive $50 a week for 1 year. One group will receive that in just money. So they'll get it loaded onto a secure debit card that they can spend as they wish for a year. The other group, we wanted to see more of the impact of what increased nutrition can do. So not just access to more food necessarily, but better nutrition. So they'll receive money to a grocery store, and they'll also receive a facilitated grocery shopping trip online once a month to basically just help guide and introduce participants to healthier foods. And they'll also throughout the year receive nutrition education. Both groups will receive that. So you don't need to look too closely at this, but basically it's just a summary of what we'll be doing. So throughout the year, the participants will attend a study visit once every 3 months where we'll collect anthropometrics. We'll get the baby's length, the weight, the parents' height and weight. We'll have them fill out surveys to explore social determinants of health. We'll look into everything from their demographics to incarceration history to income, education, everything. We'll also dive into their dietary recalls for both the caregiver and the baby. They'll be done a little bit separately. And then we'll also ensure that they are using their benefits. So if the families are eligible for WIC, we'll make sure that they're actually using them, or at least feel that they have access and feel empowered to access those resources. And And we'll also be collecting a little bit more data along the way. So we'll be following their purchasing data as much as we can, as much as is possible. And we'll also be pulling information from their medical charts, any other social drivers that we can find, any other comorbidities, family history, things like that. We'll also be linking to some national data sets to collect, so we can kind of overlay any other factors that might be impacting the child's growth. From there, so babies will be officially enrolled when they're 12 months old. They'll participate for a year. And what we'll be looking at at the end of their participation is to see if their BMI trajectory changes. Of course, BMI and growth will change, they're growing babies, but if that trajectory changes and if we can knock them out of the obesity category. And we'll also be looking at food insecurity and nutrition outcomes. And so what we think will happen, of course, we're years away from knowing, but what we think will happen is that all families, we hope, will experience an improvement to their food insecurity, that will be mitigated. And but we do expect better health and growth outcomes with the family that gets the more targeted nutrition intervention. So that's where we're at. And yeah, happy to answer questions after.
So we're going to transition now to speak a little bit about root causes and the Fresh Produce program, but I believe there's going to be as well a little bit about the community health. So give a broader context to what is going on in Durham County and what has already been shared from the federal level. What we see in Durham County is not that much different from national statistics. It is worth noting that Durham County does have similar disparities to the national level for African American Hispanic that is being shown and collected here, just to give more of a context to where we are landing ourselves for our conversation. Would you like to talk more about what has been going on with it?
Yeah, sure. So Duke Health and the Duke University have both kind of put into writing their intention to focus on food security and nutrition security for students, staff, the broader community, and their patients in the form of their strategic impact plan, as well as and that's on the university side. And then on the corresponding health side, there's a strategic enterprise plan that emphasizes health equity and prioritizes food security as one of the kind of targeted interventions for improving health equity for Duke Health patients and for the broader health and well-being of kind of Duke's community across the state. So within that strategic impact plan from the university side, they targeted food and provided 4 specific kind of areas that they're interested in prioritizing food and nutrition security for those 4 different populations that I shared. So focusing on access and affordability, investment, waste reduction, culturally ethical, relevant foods. So these are some of the kind of high-level priority items that have kind of made their way to these strategic documents. But and that's a huge success that they're actually kind of in these documents and are kind of guiding principles that focus the work. But now, it's about doing the work and actually kind of defining what some of these sentences mean. And that's what Duke, both the university and the hospital, are in the midst of trying to figure out right now. Both how are these concepts being pursued and defined already by partners like the Nourish study and by the Fresh Produce program. So there's already a lot of latent resources and expertise that's already been kind of in operation across the health system. But as the statistics show, that these food inequities have continued to exist despite these programs existing, for as long as they have out of Duke. So while these interventions and these different programs have found in their own way success, there's still a lot more work to be done. And that's a part of what my responsibility is as the new food and nutrition security coordinator, is helping really communicate to the Duke community that these priorities do exist, that folks at the top levels are really interested in food, nutrition security, and working with folks like yourselves, students, staff, community members, to kind of get us all working together and kind of in cooperation with each other so that we can drive those food inequities down. I can talk more about specifics, but that just sort of lays some of the high level groundworks. But a lot of this work, again, is informed by things that have already been happening. So I'll hand it over back to Elijah to talk a little bit about what Duke students have been doing to really inform the administration, both at the hospital and the university, how to actualize some of these priorities.
Yeah, thank you. So, I mentioned at the very beginning a program called Root Causes and the Root Causes Fresh Produce Program. I don't want to take any credit because I wasn't here when it was founded in 2017 during the model in which it was, for example, working at outpatient clinics and more directly with patients. I came in during the pandemic. And what's really important to recognize about that is that created the model that you see on the screen there. So we currently, as a fresh produce program, use a delivery model direct to the doorstep of food insecure individuals in Durham. From the very beginning, it has been based out of clinic and community referrals, but more recently, specifically clinic referrals. Once providers provide that referral directly to the fresh produce program, we have members of our team, primarily students, that are screening, consenting, and enrolling individuals into a bi-weekly delivery program. So they either receive produce on the first and third Saturday of a month or second and fourth Saturday. And it's also important to note that the nature of our program and what we at least try to do is one that is done to be communicated in both English and Spanish. And so we have done our best as a program to develop mechanisms to allow for that enrollment. And then individually also sourcing produce from another of other places. Really want to point out the Duke Campus Farm in particular, where we very recently developed a partnership with them to receive the majority of produce that they grow in order to and being given that responsibility to divert it towards food insecure populations, which we can talk more about. Then everything really culminates, at least for our program, the Fresh Produce Program, on Saturday mornings, where all of our produce culminates to one location, Farmer Food Shares Food Hub in East Durham, or east of East Campus in Durham, I should say, and having different volunteers, primarily students, but also staff, faculty, community members coming to pack produce and deliver produce directly to the individuals that this program serves. Who does this program serve? A little bit, these statistics are hopefully representative of what we are aiming to address, primarily with understanding chronic disease, but also capturing a lot of the statistics of food insecurity in Durham. We overrepresent relative to the food insecure population in Durham of historically excluded communities, and are seeing a rise in, for example, our pediatric population relative to how we used to because of partnerships we've developed, like with the Healthy Lifestyles Clinic. So hopefully this gives a good framing to what the program is now and where we sort of situate ourselves. And so the program, the Fresh Produce Program, has been fortunate to be in a situation where it's able to support a number of not just community level efforts, but research initiatives that are also stemming from the community. So listed here are just a little bit of information about all three of those. The one at the far left is describing Arreglados Juntos, which is a research study that we recently completed and are working towards writing up all the information about, but essentially identified individuals in Durham who were food insecure, had a primary diagnosis of hypertension, and had a self-identification as either Hispanic or Latino, and enrolled them into one of either two arms, intervention or control. Similar to, it sounds like what was going on with the NURSE study, we really grappled with the fact that every person we were enrolling was somebody who had screened positive for food insecurity. And so we did have a control group, but they were still receiving food when we would conduct in-person data collection sessions with them, but we're not conducting education sessions with that group, as we were pairing we're pairing the nutrition and the direct provision of produce with education sessions of nutrition that were language concordant and conducted by dietetic intern students at North Carolina Central University's dietetic internship program. And I can talk more about sort of the result, sort of finding them, but it is supportive of the fact that these interventions are making an impact in regards to blood pressure for the individuals that we enrolled. There was a lot more going on with this study in terms of community intervention that hopefully we get some time to talk about. I want to mention briefly that because we are housed within Duke in different formal and informal contexts, we have a lot of connections to programs, not just with School of Medicine where it was originally housed, but also undergraduate units and undergraduate programs, which is how I myself got looped into this program. And as part of that, Vast Connections. So for those unfamiliar, Vast Connections provides funding for interdisciplinary research teams to form. And that is actually how I got involved with the Fresh Produce program when I was a freshman at this university in the pandemic. And in particular, a team that was at the time led by Dr. Vivina Martinez-Bianchi and other medical students that were really interested in looking at some of the previous statistics of rising in food insecurity and rates of COVID transmission among the Latino population in Durham and trying to identify what was going on there. What more can we glean from the experiences of this population? And to try to abbreviate an entire year of research where we interviewed a lot of different individuals representing community-based organizations, we found that policy was something that could not be ignored. It was conducted with much more of a clinical interest, but the reality was what we kept on coming back to is, what about public charge? What about SNAP? What about all of these infrastructural barriers and challenges that were coming up for members of the Latino community in Durham? And over the course of my time at Duke and also other things going on within the broader Duke ecosystem, having a new opportunity to investigate these questions that came up about nutrition policy is what led to the current Vast Connections that us as some of the members of this panel are working towards today to answer some of the questions about the Fresh Produce program. I'll kind of end my section here by saying that we have these statistics that we are able to report because a lot of them are self-identified, but there are a lot of things that we don't know about the populations that are being served. And also, as has been referenced, a completely independent walk-up table, very similar to a choice model for a pantry. We don't know a lot of information about these individuals. And up until now, that's been very intentional to foster trust and develop a mutual understanding of what we are trying to do and providing produce. But when you think about the systems that we're in and people wanting to know things about the population that we serve and how we can use that information to effectively create structures that actually support these individuals, that's a big motivation for what our work with this Vast Connections is doing, trying to answer basic questions. How much do the individuals in the program use other programs? Are they on SNAP? Are they on WIC? What challenges have they had if they were on those programs? And what does their involvement with the Fresh Produce program imply about what may be the challenges that they're facing? So there's a lot of questions that we are hoping to answer through this work and other similar work, both policy and clinical, and it's easier said than done. So I'll turn it back to see if we can start a conversation.
Just one thing I wanted to add to kind of complement what you're talking about, that also I think explains a little bit about why this community health panel here is eager and was excited to present to y'all in this global health context, is that there's the slide shows that there's a huge ecosystem just to pull that little project off. And while it was really informative, it kind of revealed more questions than answers. And so kind of thinking about this ecosystem and this work that we have to do that's still getting more questions, I think we're trying to appeal to the global health community, because what we're finding is that, all of the bad news that we read about war, famine, climate change, all these things that are contributing to mass migration that we know is a fact and is a reality for the future of us. It is driving folks to come to our community through a number of different reasons and contexts. And as community health minded folks, our community is changing. It's expanding because of this mass migration. And we need to figure out how do we adapt what we're already struggling to pull off to meet the needs of this evolving community that's now involved from all over the globe under all different kinds of circumstances. So as much as we're here to hopefully educate a little bit, this is kind of a plea and hopefully an opportunity for you all to understand the work that we do and understand your place, your role in the work that we're doing as well. So if we don't answer those questions or make it clear, come up and talk to us and we can find ways to work together.
Thank you. Yeah, and thanks for sharing this really interesting research you're all working on. I think for now, we're going to pose a few questions to the panel and then going to turn to audience Q&A. So first, I know we've talked a lot about nutrition access and food insecurity, and I'd kind of like to disentangle or distinguish between what we mean by food access and nutrition access. And so I think I'll direct this one to Scott first, but how does nutrition access fit in with our discussion on food insecurity? And what are some ways that federal and local food assistance policies and organizations like Root Causes can help address nutrition access in particular?
Yeah, so I'll kind of naively answer, not being medically inclined or medically inclined, but not medically trained. I think when we think of the difference, it's really just, is the food healthy? And, at Root Causes, we have kind of distinguished, or not distinguished, but have thought about the difference between addressing hunger versus addressing health. And that difference, I think in my mind, lines up with this difference between addressing food insecurity, nutrition insecurity. I think they both have a place of, people need to get access to something to eat. And that's a very important part of people's ability to eat or, kind of self-actualize and find, enjoyment out of life. But I think as medical students and coming from the medical area, I think we were trying to provide opportunities for people to choose if they like to have nutritious food and also address their hunger on a scale of a year or on a scale of an afternoon to make healthy choices to address that hunger. And I think the broader question or the other question was like policies to support that or, yeah. So I think there are different kinds of policies, certainly. I think there are small scale policies of like on a clinic or on a physician level, they may make an internal policy that they are going to care to ask about the food needs of their participants and become aware of community resources that they can share with their patients. Soon there will be more hard requirements that healthcare providers screen for these social determinants of health as a matter of being accredited as a healthcare system. So that's going to be a big shift that we'll be seeing where screening for health-related social needs like food, transportation, interpersonal violence, housing, those are things that doctors and healthcare workers will have to ask their patients about. As a means to measure these needs, that begs the question, okay, so once we measure these things, what are we able to do about that? So there are policies, financial policies that are coming through insurance payers, or in some cases through federal funding programs that are enabling traditional healthcare providers to get compensated for providing health-related social needs. And it's not just hospitals that may be able to receive money to provide food or transportation, but it's also nonprofits that have already been doing that kind of work may be eligible soon to receive money through programs like Medicaid or through insurance payers, like the one that you may have, to provide food and provide these other kinds of preventative health measures for all patients, and particularly those that for social reasons, for economic reasons, are not able to access those. So there are things on the horizon. For specifics around like Medicaid, you can learn about the Healthy Opportunities pilot that is just concluding this year that allowed for Medicaid to pay for these preventative health things. As an example, but there is encouraging policy changes that are enabling and reflecting, I think, this turn back towards preventative healthcare, which makes me excited about the word. Yeah.
Yeah, and I know SNAP, there's been a lot of debates, in particular about SNAP, but one initiative that's being tested out is potentially incentivizing people to make different choices in the grocery store by providing more money towards certain types of foods. So if you were to purchase produce, then maybe you'd increase your SNAP benefits by 20%. So I know there's a lot of nice control trials in that area, and it's a way to kind of get at this, addressing nutrition access as opposed to just food access, because see that the food environments across the US are very significantly based on where you live. And in some areas, you may have access to food, but it may be fast food and foods that really lack nutrition, but are high in terms of calories. So I think it is something that's important to distinguish as we move on with this conversation. I know a key theme of this talk is pursuing community-based participatory research and how it can help ensure equitable access to food assistance resources. Elijah, I think I'll direct this one to you first, but can you talk more about what is meant by community-based research and how it can be beneficial in addressing food and nutrition access?
Yeah, so community-based participatory research is more of an umbrella term, I would add, that encompasses a lot of different ways to actually conduct research. On that spectrum, I would say that a lot of the work that is being done right now is very community informed, and including community members as a part of, or receiving feedback from community members about that study design. There are other aspects of how you can design research to be more community engaged or community informed. One aspect of the Arreglos Juntos study that I didn't mention is that we included and made sure to include community health workers as a part of the study. So we made sure that we had members of the study from El Centro Hispano, which is the Latino community-based organization that provides for community health. That provides community health workers for community health oriented goals within Durham. So one thing to know about what it means to include them, and there's a lot of implications about what it means to include members of that community who, for example, as people who, the distinction between having members of the community who are involved in the research as a participant versus members of the community who are involved for the purpose of actually conducting and collecting research or collecting data and being a part of, for example, home visit process, and what does it mean for them to be included. That is on that spectrum of what it means to have community engaged research involves them a lot more deeply, because they are given opportunities to actually change what it means to be doing your research. And I don't know if there's any aspect of Nourish, and I believe you can speak more about that, please. But I know that for what we have tried to do as a program, when we have done research, is yes, there's a lot of people who are traditionally not as involved with research design and actually providing input. And the reality is it is better that what I would argue we have been able to do is involve community members to actually be a part of that study design, be a part of that data collection, and not just be somebody who was asked at the very beginning what would maybe make the most sense. And that is something easier said than done. I don't know if you want to speak more about how that's been.
We did work that concept into developing the Nourish study. So going into that, before we developed this intervention, we interviewed 42 caregivers of children that receive WIC and asked them everything there is to know about their grocery shopping habits and everything that they liked and didn't like about their SNAP and WIC benefits, and just really tried to get at the influencers of how families acquire food, the experience of food insecurity, the experience of receiving benefits, and then actually proposed our intervention to our caregivers and asked them to poke holes in it and just said, here's what we're thinking of doing. What do you like? What do you not like? Can you give us some more ideas? And that way we were able to really hone in on, I mean, most families just said like, we know what to eat, we just need more money. And so that's where we got to just giving cash to one group and not assuming that folks just needed nutrition education. And so it helped confirm some things we were going to do. And it also helped us move in a totally different direction from some of the other ideas that we had. And I think that, yeah, that kind of research will help us make this next research study a lot more effective and a lot better received, and honestly increase the number of people that feel interested in participating.
I mean, I think the reason why we're doing this research is for hopefully long-term interventions or transformation of the healthcare system. So like, people don't want to participate in the research, it's not gonna translate well to like when we actually roll out the program as a norm in clinics and across hospital systems. So as much of a priority as important as it is to start with the community-based research on its own principles, just like for practicality's sake, like it's the smart thing to do. Well,
And the very last thing that I would add to that, so we looked at all of these disparities and this data on the screen of we want to potentially be doing more to address disparities in African American communities, Latino communities. But when a lot of the literature and the research that has been done for a lot of these things have primarily enrolled white participants, there's this question of what more needs to be done. It may not, if they are going to be included and actually try to have research that addresses disparities and includes communities who have been historically excluded, they need to be a part of that process. And from the researcher's perspective, if all of your knowledge and the literature out there is fully based off of non-representative communities, there needs to be more work done by the researcher to make sure that what you're actually going to be putting your research efforts into is representative. And easier said than done. Again, it's not always perfect, and there's a lot of ways that I don't know about Nourish, but like there are ways that I wish our study had been better, trying to involve more and include more, but making those steps and being clear about why you're taking those steps is in a lot of ways maybe as important as the findings of the research themselves, especially in some of the spaces included security, where it may or may not be surprising the results that you get, but knowing that it is specific to these communities that have not yet been represented in that research is something that we have been focusing or trying to focus on.
Yeah, and I'll also add to that, like there needs to be more emphasis on a mechanism for getting academic research to organizations who it may benefit. So as I'm quickly realizing, very few people read academic journals. And the people that are probably not the people that would benefit from a lot of the information we have. So I think I actually come from a land-grant institution, Ohio State, and I kind of assumed academia operated in that sort of model where professors are going to have some form of service requirement and traveling around to talk to farmers and their stakeholders, but it's not seemed to be the case across most institutions in the US. So really kind of push for a better mechanism to disseminate information and interesting studies that we are doing. And to push to the final question before we jump into audience questions. But I know Elijah kind of introduced this, and it's a good segue. I think it's clear that there are large disparities across the US in food insecurity rates and access to resources. What are some steps that local organizations in Durham can take to help address these disparities? Because what we're getting at with our Basque Connections project is we see that SNAP take-up rates which is the percentage of people that are eligible for SNAP um, that actually enrolled. SNAP take-up rates vary significantly across races. White households enroll at a lot higher rates, so there are things that local organizations do to help with these issues and decrease disparities. And I guess I will go to Scott first for this one.
Yeah, sure. I mean, I think there are a lot of wonderful community-based organizations that have really great missions and are already doing a lot of good work. I think so I could just list off any number of those and just like giving those organizations more money and more support and more students to help them with the work that they're doing. Those are all good things. But I think like in general, I think like the more we think kind of systematically or like as a system and kind of realize kind of how interconnected all of our work is, I think there's a lot of opportunity there to find efficiencies in the work that we're doing. I think through that, I think in addressing qualities and like understanding our partners in food systems, I think it also helps create more community and like we're just feeling more a part of Durham, like this is our home together, which I think is like after we address food security, then we have to, you know, there's all these other challenges, not to mention like enjoying life. And so I think like the more we can do to just connect with each other, to understand each other's challenges, not only helps address those challenges, but it helps create community. And maybe kind of sets us up, or at least sets our future generations up to avoid being unaware of other cultures and other, what the community needs are, that the community and students, Duke, Durham is all kind of one and the same. That'd be ideal, but
Yeah, and to that point, there was a big summit, Powering Eaters on Sunday, and I know we had a lot of discussion on community gardens and not only a way to kind of address nutrition access, but also a way to address things like loneliness and a way to kind of form community, like people to come together in the community to do something like gardening. So.
and to that point, I have to plug. So on March 28th in Durham, there's gonna be another food summit hosted by the Office of Community Health, and it's free admission for everyone, including people in the audience. It's unfortunately not going to be streamed, but we'd love for people to come out and participate in that and continue to engage in that community. And to my point earlier of having these high-level priority things listed in the strategic plans, but needing to really make those plans concrete. These community events, these panels, things like just literally getting in front of folks and around other people is how we make those documents really alive. So encourage you all to consider participating on that summit and joining or letting your friends know.
I'm also hoping that, so just in terms of increasing access and what policies can change, I think that leveraging what's already there and leveraging the places that people are already going. And I mean, I have the clinician hat on still, and I feel like medical care is something that most everyone receives, especially children. And so taking advantage of medical clinics generally being an already safe space for people. And even if you're just like, collaborating and connecting the resources, like letting us know about root causes so we can refer, but I think opening up our pantry within our clinic, and we renamed it a market to make it less stigmatizing to go to. There were a lot of families that we found out there's been a lot of research on our pantry that we have. And there were a lot of families that identified as having food insecurity, but were not accessing the resources in Durham until our pantry opened. The reason being, they didn't feel good about going to like a specific place to access those resources. Some of our participants and our patients are undocumented, and so it felt very unsafe to go to those places. There might be a sting, they could get deported, and so, but everyone generally accesses healthcare, and so kind of leveraging like places in people's lives that they're already going to on a daily, weekly, monthly basis, or even annually, just to tap into it's already a safe space that they can go to, and then seeing how many resources they can get from that one space, I think would be a good way to increase access.
So I guess we have 8 minutes left. So now I'd like to open it up to audience questions. People on Zoom can submit questions through the Q&A tab, and people in the room can raise their hands.
Yeah, thanks. Thank you all so much. I have a question in terms of research. In global health, we encounter some of the most interesting barriers or kind of hoops that we have to go through. And I'm really curious, especially as we've made reference a lot to immigrants and undocumented folks. For example, I know that at Duke, the policy makes it very difficult to reimburse research participants who don't have Social Security numbers. So I'm curious, what other barriers have you guys encountered in research work? And more importantly, what solutions have you seen used or have you guys come up with for some of those barriers to including a population that's even at higher risk for food insecurity?
So I'll take the first part. You probably have something to say too. So we actually found a loophole for the Social Security waiver. Well, if we have a waiver that you can get folks to fill out as long as they're receiving less than $600 in some kind of compensation. You can compensate them in gift cards instead. And you have to justify it. And we just say we work with a population that is at risk, and we don't want to, sway our data by not having them feel like they can participate. So, and there's a whole email chain.
Sure.
Of getting it approved by like 10 different departments within Duke. But then once you get the go ahead, the other thing, and Elijah spoke to this earlier, is, making sure that there's representation. And so our group specifically does go out of its way to hire Spanish speaking coordinators. And so all of our research to date has involved Spanish speaking population as well as English speaking. And so and we're lucky to have that. We basically recruited a lot of interpreters from the medical clinic over to the research side. And so those are the barriers that we've been able to overcome.
Yeah, we also are just now encountering the Social Security waiver as well. Another barrier that I just want to mention from the Arregados Juntos study is the process of actually involving individuals who don't speak English onto a research team ended up becoming much more challenging from the Duke end than we had anticipated. People are likely familiar with city training and ethics training. Those are not very available in the Duke community in a language other than English. And so that is something that we had to navigate for our community health workers that we tried to include in our project. One of them who spoke good enough English, Spanish that they were able to get by on the English version, but didn't feel very comfortable. That's another thing to note. How much did they really retain from those trainings? And the other one who just did not feel comfortable doing it in English. And all of my communication to that individual has been in Spanish. And it was really important in those initial conversations that we have them onto the team. We agreed as a team we need to have them. But I'll just say that process took so long to get them enrolled that the CBO then had to pull them from the project, and we had to replace them with new community health workers halfway through the study. That changed the entire trial period. And Scott's nodding because he knows very much what that process was like. And so not all of that may be chalked up to just like infrastructural barriers. There was also the challenges of CHW funding from the state to the CBO because we were out of COVID now. That's a separate conversation entirely, and it's not fully your question, but all of those things compounded to some extent because of what we had to experience from Duke as an institution trying to figure out how to get these trainings available in Spanish. It's interesting, as sort of an insight who has been on multiple studies in which there has been a Spanish-speaking population, Duke has been very clear about forward translation and back translation and making documents available to individuals, but has not been, in my experience, as welcoming when you want to include study team members who only speak Spanish or only speak other languages. So that's just an additional insight that I would provide towards that.
To answer your question though, we ended up having the community partner in that study, El Centro, receive the funding to purchase the gift cards. And then they just used whatever their role was, which was no role, or it was the appropriate rule. I mean, sure. And then, yeah, I think Yeah, Duke could probably, and this would be, so Duke has like a community engaged research department that's kind of being developed in the Office of Community Affairs. It's very nascent right now. But a really interesting thing that they could do is probably regularly offering free city training to the community. Maybe reaching out to nonprofits and say, hey, if you ever are interested in engaging with Duke research, it may not be a bad idea to just go ahead and get the city training so that if someone approaches you, and now we know to approach you because you are interested in research, they already have that, at least one barrier taken care of. That'd be a cool idea. I hope my colleagues are listening.
In the interest of time, I think one more quick question. Crowd, there are any? Not Zoom.
Yeah, we have some online questions. This one is from Stephen Paterno. And it's two-part question. So could you envision overlaying the nutrition-related education and fresh food interventions with community-facing health screenings like blood pressure, diabetes, and cancer screenings? And then he just notes that the latter is of increasing importance because especially among younger populations where the incidence of cancer has now gone up, including diet and obesity-related cancers.
Yeah, that'd be cool. And I think like something that Root Causes is interested in doing is like, our model is such that someone is physically delivering the food to our families' homes. And right now, the capacity of those volunteers, they're just students or community members, and we've taught them how to drop food off. But it would be interesting to have like a community health worker or someone who's more clinically trained be circulating through those deliveries to do some at-home screenings. And it might be more in that we are visiting these families every other week. I think we may be in a good position to have like a relationship with these families that are familiar with us and would be willing to have someone come in to their home to do those kinds of more intensive screenings. So we may have an easier time with that than other hospital systems that don't necessarily have like an ongoing relationship with their participants as frequently as we do.
Hey, well, thank you, everyone. A recording of the event will be available on the Duke Global Health Institute YouTube channel. And I'd like to thank Scott and Elijah for taking time to be a part of this panel. And thank you all for